panel discussion lined up on the topic incorporating comprehensive lactation support within NICUs, Strategies and Challenges, moderated by Dr. Srinivas Murthy, and the speakers are Dr. Teja Pratap, Dr. Swapna, Dr. Nitish, Dr. Srinath, Dr. Bharadwaj, and Dr. Santosh Kumar Karliti. I request everyone to please come on the stage.
So we are on the fag end of the day, but we have been given important responsibility of how do we incorporate comprehensive lactation support within the NICUs. And we know that this is the biggest challenge which all of us have. And in fact, the formula has come from the NICUs, and the milk banking also is coming from the NICUs. But we want to convert the milk banking to comprehensive lactation management and ensure that every preterm baby gets mother's own milk. So how do we ensure this? What are the challenges we have, or what are the solutions we have? We have just 5 questions, and we have 5 panelists here. So it will not take much time, but there will be a gist of each question will be answered by my eminent panelists. They are all expert neonatologists, public health specialists. They are also worked in neonatology and NICUs. So I'm not going to introduce all of them again. So I will go straight away with the topic. So the first question, okay, what is the lactation support needed for NICUs? Maybe Swapna, can you tell us what is the minimum requirement of infrastructure, equipment and manpower if you want to start lactation support in the NICUs?
So, if for a NICU, all the NICUs we cannot have an CLMC. So at least we should have a lactational support person who helps in establishing lactation. Every delivery, either it's a term delivery or preterm delivery, there should be a supporting staff who can help in establishing the lactation. And also we need breast pumps for expressing the breast milk. All preterm mothers should be educated how to express the milk and expression, and also breast pump. So these are the minimum requirements, and that the milk which is expressed from the mother has to be stored in a refrigerator, at least for an where the babies are being cared. Even though we don't have CLMC, at least a breast pump, a lactational supporting staff, and the fridge for storing the milk and giving the milk to their own babies.
Thank you. So that was very crisp, that you need a place where mothers can express. They need to have some privacy, and there should be some equipment for ensuring that milk is expressed, stored, and there is no processing done here, because we are talking about only lactation support. The mother's milk can be stored and labeled so that same baby can get it, or we have seen how it can be used for other babies also sometimes. And the manpower, I think the manpower, she has highlighted that there is a need for dedicated lactation nurse for every level 3 and level 2 NICUs. So I think that's very important point, that there should be one dedicated person for doing this job. So these are the minimum: space for pumping, stay facilities. Yeah, I think that's very important, stay facilities for mothers. So now we know that every SNCU should have a kangaroo ward, every NICU should have a kangaroo ward. Lactation concern, nutrition is also very important to ensure that the mother's nutrition is taken care of. Hospital grade breast pump, manual breast pump, and a refrigerator. These are the, so now the current guidelines tell that every tertiary care NICU should have a comprehensive lactation management center. All the level 2 NICUs should have a LMUs.
Just I want to add one point, sir. The existing manpower, which are the staff nurses, you cannot say that they will only manage. Either we need to designate one of them fully for this, or you need to have a specific resource as a lactation counselor.
I totally agree with that, that if you are running NICUs, we need to have a dedicated lactation nurse. There is no way you can ask the same nurse taking care of the baby to also take care of. She can be involved in lactation support, but there is a need for dedication lactation nurse, and that's very important point which we want to highlight here. Thank you, sir. So what are the benefits of lactation support to the baby and mother, Swapna?
In all aspects of breastfeeding, lactation support helps. For example, if you take a term baby, the lactational support helps in early initiation of breastfeeding and continuing exclusive breastfeeding for 6 months, which helps the baby to get discharged successfully from the NICU. And more so for preterm babies, having a lactational support so that mothers express the milk within 1 hour, and frequently they express the milk. and it gives lot of help to the preterm baby in early discharge, better outcome, better neurological outcome for the babies, better growth, less infections, and early discharge. And for mother, it decreases lot of postpartum depression and psychosis, which we were talking from morning, a better BPD outcome, the severity of ROP and need for laser, every benefit for the baby, it comes by providing lactation support.
So she has said that there is a benefit to the unit, there is a benefit to the baby, and the benefit to the mother. The benefit to the babies are not just beyond nutrition. We have seen every disease of the preterm can be prevented or managed with mother's own milk. And for the mother, so the better bonding, she's getting involved in the baby care. And like breastfeeding, for term babies, it also decreases breast cancer, postpartum depression, psychosis, and other problems also reduced. So, Dr. Nitesh, he runs a good NICU in Hyderabad, and what are the processes that have a role in improving lactation? So, admission, expression, KMC, what are the processes in all this? So, would you like to throw some light?
Yeah, thank you firstly for to the LAMCON for inviting me to be a part of this panel. This is my first LAMCON. Thank you so much. What Dr. Murki asked, I think if you should look at the principles of breastfeeding hospital initiative, although they are meant for well-term babies, they are actually applicable for all babies, irrespective whether they are born at term or preterm. So this conference, I think there are two kind of people here. One's the doctors and seniors who've already been saying and accepting the components that we are discussing today, and the other group is of the young people who are probably nutritionists, lactation consultants, or nurses who are actually keen on learning. So these 10 principles, although I'm sure we all know them, without going into them once again, they form the baseline even today for premature NICU babies as well. Can we have the next slide, please? And the next one. So the main things Dr. Murki has already highlighted about what are the main components that will help. Most importantly is the antenatal period. The gynecologists have highlighted so far about how much they are doing and how much we want Dr. Ravi Shankar and everybody else here ask them to highlight it even more as well. This could be the medical personnel, the lactation consultants, or it could be any other person who's looking after the ladies in the antenatal checkups. It's not just at antenatal, it's delivery time training or education as well. Ongoing education as to the techniques of breast milk expression, early and frequent. So many times we hear mothers saying, look, it's day 1 or day 2, we don't get milk, therefore they are not expressing. Obviously that is not the right way. There is enough evidence to say early expression, more frequent expression is the way. Skin to skin, that is KMC, again, whether it is KMC or KFC, not the eating one, but the father's one, again very important and family centric. We talk about it takes a village to raise a child comes in here. So scientific, dedicated information, not just to the mother, but the entire family that is going to take care of this child is very much important. So that is in a nutshell. So some of these slides will actually say about the same thing again and again. This is one slide I would like you to hold on for a second. So now this is a very useful chart that I could find. It not just gives a visual impression of how to express a milk for a first time mother. This is purely more for the nursing staff who are here. If you can scan that QR code over there, this will actually take you to videos, very, very good videos of how to train a young mother, how to express milk. So kindly request you to just stay on that slide for another 10 seconds. So the young people, please kind of scan that QR code and you will get beautiful videos of how to do expression of breast milk.
We'll share the slides on the WhatsApp group. So he has shown that all the principles of processes which need to be in place, right, prenatal, natal, postnatal, in the delivery room, in the NICU, what all we need to do till discharge and post-discharge, what all we need to do to ensure that every baby gets its own mother's milk. Because we cannot do anything unless we measure some things. So in lactation support, how do we measure that NICUs are doing good lactation support or not, whether babies are getting own mother's milk or not, whether mothers are able to contribute mother's milk to the babies or not. What are the measures? Are there any standard measures to ensure that our NICUs are doing as good as the other, or within our NICUs how we are performing? Bharadwaj?
Yes, sir. As you told, we are doing a lot on lactation support in the NICUs, but we have to have some measurements so that we can say, I have done so many things. So there are different types of metrics that you can use. Either you can have a baby driven like initiation of the milk, maintenance and discharge, and you can do the follow-up as well, or mother-related and nursing staff or hospital-related metrics. So in initiation, I'll not go into the details, but you can see how much the mother is initiating on the day 1, first hour, 6 hours, or on the day like day 0, day 3, day 7, or on the week basis, or on day and night basis. And also you can have like time to reach full feed in PO days, or you can depend upon how much volume the mother is expressing. So all this can be used as primary objectives. And the next, we have on the discharge, we can see Z scores, how much the Z scores the baby is on, or how many days of hospital the baby is in there, or how many infants are receiving the mom at the time of the discharge. On the follow-up, you can have how many babies are on full mom. And secondary objective like sepsis, NEC, death rate, discharge rates, and growth charts, we can use as secondary outcomes. On maternal side, you have maternal satisfaction score, how many times a mother is coming in the NICU, how many mothers are doing KMCs, how much time they are doing a KMCs, and or nursing related, you can have how many nurses are trained in the unit for the lactation support.
So just to summarize, these are very important. What was the first time of pumping? What is the first time the milk has reached the baby, whether it's colostrum or full milk? What was the first day the mother has visited the baby, or the first hour mother has visited the baby, or first time skin to skin contact has been done? These are very important metrics we should note down in the file so that we can work on improving these numbers. And when was the first time non-nutritive sucking was started? When was the nutritive sucking started? Number of expressions from day 1 till discharge, if the mother is expressing manually or by pumps. Daily volume of expression. So you need to have something written here in the charts so that you can continuously monitor this and see whether you are improving or not. Time to reach full milk. For the mother side, we should aim for at least 500 ml of milk should be expressed by the mothers when they are in the first 2-3 weeks of lactation. So that if you are able to reach 500 ml, it's called full milk, but the ideal is about 700 to 750 ml. So the number of volumes in the first and second week you can calculate. And one important metric would be to see if the baby is getting 100 ml of enteral feeds, how much of that is mother's own milk, how much is donor milk, how much is formula. So if you keep doing that, you can aim that if you are 40% of mom, you can keep thinking that next week I'll go to 60%. Or the next group of babies I'll go to 60% and then I'll go to 80% and so on. So you need to have some number game so that you can chase the numbers and keep working on it. Ultimately, whether these babies are breastfed at term or not, at 3 months and 6 months, how many are exclusive breastfeeding is the ultimate goal, but you need to have number of measurements in between to reach that ultimate goal. Tejo has done a lot of work on quality improvement projects in improving mother's own milk and lactation support in the NICUs. Tejo, can you tell about your experience of the QIs in which you were involved and what QIs did help you in improving the lactation support and mom?
Thank you. So 2 QAs which we have recently done in the last 3 years which have shown a lot of impact. First one, this has been published already. This was to look at improving the mother's own milk in VLBW babies from the existing to whatever the best that we can do. So again, because this is one of the most affordable thing for the babies also and then doable, which will improve the outcomes as Dr. Sapna was saying to us. And then we thought that we will run some root cause analysis and then do the PDSS cycles. You can go to last, maybe fishbone analysis and other things. Yeah. So for any QI, these are the 4 P's which we have to review. That's a place, people, process and policy. Where we are having the issues, that's what we need to pick it up and then start doing the PDSS cycles. So we have run through different PDSS cycles and the same thing. So initially, the cycles which have given us lot of improvement was, one was the dedicated lactation nurse. So what she used to do is that she used to come every day to the NICU and she used to stay from morning to evening and she used to spend the time continuously with the mothers who are coming for the KMC and also coming for the counseling and other things. So her job is only to see that all the level of education, and then number of times the mother is expressing the milk and giving the proper advice, whether it's a day or night expressions, and then how much she was able to get it, and try to give them some tips on increasing the mother's milk output. And for educating other things, we did the feedback, we made a leaflet separately and then started doing it. And then we also kept that, because some of the mothers who were long staying, they might get exhausted with the manual expression. We thought that we'll provide them from the hospital only a pump, and then we will try to see how it will impact. So then when we saw these impacts, so you can go to last one. Yeah. So you can see to display this run chart, because this will help us, all the team members who are working, they will try to see how the improvements are occurring, and they feel positive feedback will be there, and then that will try to help us. Then we used to keep this dashboard. Now it has become digitalized a little, but during that QA it was the thing. So this will give reflection of everyday work, how many babies are on enteral feed, and then how many babies are mother's own milk. So as you can see, major impact was there on the education and having a dedicated lactation nurse and the pump. From the existing 50%, we were able to go up to almost near to 90 to 100%, and this is still sustaining.
I think this point is very important. You can see that at the beginning, only 50% of the enteral feed was mother's own milk. By the time we finished the QI, it was 80%. So 80% of enteral feed was only coming from the mother's own milk. And you can see that after finishing the intervention phases, when you involve all the interventions, it has gone up to 88% from admission to discharge. From the time baby starts getting feed till he is out of the NICU, if you take the total volume of milk, 88% of that was only mother's own milk. This is a wonderful achievement, and when we compared across the globe, this is the best achievement which could have.
And that's how, and there is a balancing act. Initially we thought that whether just by promoting the mother's own milk, whether we'll have the donor human milk available for us or not. But to our surprise, we have to bring one more refrigerator to accommodate the extra milk what we got it, because the mothers were producing so much that we have to take them for the
So
refrigeration.
we need to buy one extra refrigerator to store the milk, because every mother was producing more milk than what the baby wants. So in fact, if you start doing this, you will be surprised that most mothers produce almost double the time what the babies can take. So that extra milk is going to be used by milk bank. So this is actually, people thought by having milk bank you might decrease mom. But we found that by using mom, your milk bank is full.
Sufficient. And in fact, that's not a 100 liters fridge, it's a 400 liter fridge. That's what you need to remember. So that much we were able to make it. Okay. Second one was on the late preterm, we just finished it now. Because this is one group which we neglect, late preterm. So the babies who go to postnatal immediately, they will try to go very easily. VLPW, we are concentrating because they are staying with us for a long time. Late preterm, they will stay only for a couple of days, and either they will go to postnatal ward, or sometimes they will go to postnatal ward and there only. And many of the mothers also might be having some issues in terms of medical issues and other things. So they are in between the term and VLPW, but they are not term. So we need to give them a little help. So when we did these QI, we have done a lot of, again, PDSS cycles and the same. One is that we introduced the standard antenatal counseling. Our people used to go and do the counselings for these mothers in the OBG ward, OBG, OPD also. And then KMC and other things which we did it. And the last slide, next slide, yeah. The impact was maximum when we did promoted more KMC, said next, okay. KMC and the assessment with the latch score before discharge. So KMC has helped in the late preterm, and then the latch score, which assessment we were able to customize it. And second thing, we also looked at the 3 months outcome in these mothers also. That got sustained even for the 3 months, exclusive breastfeeding rates. That means that if you are able to catch hold of them in the first 2 weeks, definitely your exclusive breastfeeding rates will go to higher. So this is the...
what he's saying is not only very low birth weight babies, the chunk of babies who come to the NICU are the late preterms. So there is a need to work on quality improvement even in the late preterm. You start prenatal, natal, postnatal and post-discharge. All these interventions are going to help you in improving the breastfeeding rate in the follow-up too. Santosh, you wanted to?
Yeah, I just wanted to comment. Can you go back 2 slides? This is the most important slide I felt, because usually compliance during QI is very high, and once the QI is over, sustenance period, it falls down.
Yeah.
There's a dip. But I think this is very miraculous that during sustenance also you could actually improve upon the numbers. What is the secret sauce you had?
No, it's a team effort actually. We involved all the people, including the obstetrician lead, and then the lactation counselors, and then our own team members, and then they have formed a team and they're reviewing every 2 weeks on this sustenance phase. So one more thing, sir, as in the Bharadwaj's question, one more indicator, though it is negative, like number of tins used per month.
So number of formula tins used per month is another indicator which you can use whether you are doing well in your NICU or not. Is you should be aiming to coming into 0, or 0 formula unit is what you should aim
That's
for.
what we need to...
Correct. So I just want to end that these are the 5 drivers. From this panel, if you take these 5 drivers home, I think the panel job is done. So education of the mother, father, family, nurses, doctors, policymakers, hospital administration, everybody should be educated that it's a mom that drives the babies, it's a mom that helps the babies. Second thing is pumping should be promoted from day 1, because these are small babies, cannot be on the breast, so pumping 6 to 8 times a day. Night pumping is as important as day pumping, and mothers should be equipped to have good hospital grade breast pumps when they are doing frequent pumping, especially for very low birth weight babies. Third important thing is promote bonding, make the mother involved in baby care, give 24/7 access of the baby to the mother, continue skin to skin, non-native sucking, and involve her in all the bonding process. Also take care of maternal nutrition and maternal health. We have seen that if in the skit we have seen that mothers, what do? They don't take a balanced nutrition. We need to ensure that nutrition and hydration of the mother should be maintained. And last but not the least is very important to maintain a data. You need to have some identity of how do we know that you are giving ideal lactation support. These 5 drivers keep implementing in the NICU till every baby going out of your NICU is breastfed at term corrected age or at 38 to 40 weeks. So till that time, if every baby going from NICU, 100% of babies are on breastfeeds, then you have achieved the target of the lactation support in the NICUs. So the last, because we have a health specialist here, and Santosh is connected to most of the organizations in the country, right from medical colleges to NMC to NNF to IAP, social organizations, NGOs. So what are the policy decisions which are required at organization level, society level, and at the government level for lactation support in the NICUs? Santosh, would you want to highlight on this?
Yeah, I think I would like to go back to the previous slide and we'll use it as a base slide. I think one of the most important things, there's a great data scientist, his name is Edward Deming, and he said, everyone in God we trust, everyone else bring data. So we all believe in God, but please bring in data. And without data, we will not have the first 4 points. Education, pumping, bonding, maternal health, nutrition, everything else just cannot be done if you don't measure. So first and foremost thing that needs to happen for any decision at the policy level or any level, Dr. Nitasha, is measuring data. Okay? So that is the most important thing. So let's measure data in every NICU. So I think one of the most important points that needs to go from this forum is that we need to measure data in all our NICUs. If we measure, you can inform your hospital team, you can inform your management, you can actually ensure that the decisions they take are right. For example, if you don't measure what is your breastfeeding rate, you cannot tell your hospital management that you require extra lactation consultant or counselor in your NICU. You just don't know. You are playing a blindfolded game. First and foremost important policy has to be formed at the hospital, not at national government, not at state government, not by the district collector. First thing is at the hospital. The hospital superintendent must be your friend. The medical director must be your friend, and for that you need to measure your data. In your NICU, if you are having so much of formula feeding done, you measure that and tell your hospital director that there is so much of formula feed which you are giving. I need a lactation consultant, I need a lactation counselor support, otherwise no one will listen to you. So please ensure that in your NICU, you ensure all the statistics that Dr. Murki sir was saying.
So
I think that is the first and foremost thing.
Just to summarize, at least measure 3 things. One is when the baby got the first dose of colostrum. So this is very important, first dose of colostrum. Second, in the first week, whether the baby is fed or not, and if he is fed, how out of 100 ml of milk or enteral feed, what proportion was mom. And the third thing as a discharge, how many of your babies are on either breastfeeding or exclusive mother's milk. And then at term corrected age, how many of your babies are on breastfeeding or on formula feeding or mixed feeding. So these 4 metrics if you measure, I think the policies can come in.
Absolutely.
Yeah.
And another important thing is, if you have at least 2 or 3 people who can support the cause of this, please take care. For sure, you have so many good people around you. The biggest support that Nilofer Dhatri Mothers Milk Bank got in terms of policy was from simple people, mothers who have been coming to our hospital to donate milk. The mothers have actually taken the word across the Hyderabad city. Lot of mothers actually were the policy, they were at the forefront. They spoke to many big agencies, and they brought lot of people to Dhatri Milk Bank and Nilofer Hospital. So I think the foremost thing in policy is your mother support groups. Mother support groups are one of the strongest in terms of policy advocacy.
I agree. So these are some of the things which is Government of India is already advertising that KMC ward should be there with every NICU. Concept of high KMC is coming up. So there are a lot of mother and child hospitals are coming up where there is zero separation should be between the mother and baby. All the very low birth weight babies should be cared for by the mother's side. Obstetrician should take care of the mother, and baby should be taken care by the pediatricians or by the neonatologist.
I just want to add one little thing, that the NNF has brought a wonderful thing that, for all the level 3 NICUs, you need to have a comprehensive
CLMs.
lactation management support.
Yes.
Similarly, in National Medical Commission, we have doing a lot of advocacy that any DM neonatology seat, it must have a minimum of a lactation management unit support.
So I think that's a big policy change. We should clap for it. Santosh is also part of NMC, so I hope that all the DM centers will have CLMCs. So it will become a part of the rule, isn't it?
And NHM, National Health Mission, in the year 2014 and 15, through Mother's Absolute Affection, is supporting 32 lakhs of capital expense for every government hospital for CLMC, 18 lakhs for a lactation management unit, and 9 lakhs for a lactation support unit. And year on year, they also support operational expense. There's a lot of support that is coming from NHM. All of you who have a smallest, working relationship with government systems can get this funding through National Health Mission in their program implementation plan, PIP, in which you can get a sanction of this money for your milk banks in your hospitals.
I think all the people working with the government or governmental organization, please note this point. You have a lot of money which is unutilized. This goes back again to the central government. So NHM fund should be utilized for establishing CLMCs, LMUs, and also stabilization units.
And wherever you really need a lot of support, Sushena
is there.
Foundation and Dhatri Mothers Milk Bank is there to support you.
Yeah, if any one of you wants to start a milk bank or a CLMC, Santosh is openly saying that we'll be doing, we will build, we will operate, and then we'll leave it to you. So finance, build, operate, and give it back to you. So any one of you are interested, please come back to Santosh and we'll do that for you. Thank you. I think we have finished 1.5 minutes before time. So thank you. Thank you all the panelists. And
Thank you.